Good evening, all. So, we are back again. Happy New Year to all of you. And with the part two of the cardiopulmonary exercise testing, the first part we did it on in December 2025. We ended it with basics of cardiopulmonary exercise testing. And now we are on with the special situations in cardiopulmonary. We have exciting speakers with us. But I would like to thank the Indian Chest Society President, Dr. Rakesh Chawla, the Secretary, Dr. Amita Nine, who has been a strong force in conducting all these seminars. And a big thanks to Vipul from CIPLA, who has been a strong support in terms of academic coordination and partnering and getting things done. And to Sheila, Mr. Amit Tikku, who has a big support in terms of helping us with the the partnering in financial partnering. And we have an amazing set of speakers who are here. So we are going to cover on different types of topics today in terms of unexplained dyspnea, which is the most important cause why we do a cardiopulmonary exercise testing. And then we will touch upon, because we've got amazing speakers in different special situations in terms of if you're going in high altitude in athletes. So how do you look into it? And in case of a preoperative, what is the role of CPET in preoperative? And the other most challenging thing is the complex cardiopulmonary things that we are generally seeing in our routine practice. And we will dwell more on these. So without much ado, I will leave it to Dr. Johnson to initiate the talk. I will introduce Dr. Johnson. He is from the United Kingdom, and he's a director of medical education and consultant respiratory physician, lead for the pulmonary physiology, sleep, and ventilation. He is currently working at Mid and South Essex NHS Foundation Trust, Basildon University Hospital, Basildon. And he's an honorary clinical senior lecturer, University College London. He's a visiting professor, Faculty of Health, Medicine and Social Care, Angela Ruskin University. And he's a visiting professor of AIMS, Rishikesh, India. Sir has immense knowledge and practice, and he currently practices predominantly in the cardiopulmonary exercise testing and sleep. That is his major areas of interest. Sir, over to you for taking us through the journey of unexplained dyspnea.
Thank you very much, Dr. Subrata. Can I share now? If you quit sharing, I can share. Yeah. Okay. Can everybody see and hear me?
Yes.
Yes.
Excellent. Thank you very much, first of all, Dr. Subrata and the Indian Chest Society for asking me to give a talk at your webinar. And I'm delighted that you've had the basics of cardiopulmonary exercise test in December last year. So this, as Dr. Subrata said, is one of the big reasons why we do cardiopulmonary exercise test. There are other indications as well, as you're aware. But as respiratory physicians or chest physicians, this is probably the most exciting bit of cardiopulmonary exercise testing. So that's what we will look at in brief detail. So my remit really is to give an overview of what would be done in by using cardiopulmonary exercise testing in unexplained breathlessness. These are by law my disclosures, and Dr. Subrata has already mentioned all of this. And it's good to see some of the people that I've worked with in India, Dr. Dua and Barney Issac, and I work with both those institutions as well. So it's been a delight to work with them and to actually participate in your webinar today. I think it's always worthwhile asking a question before you start. If you say you have a patient who is 60 years old, short of breath on exertion, if you say the history is rather unremarkable and there's a family history of heart disease, which would be the case in most people, your resting cardiac respiratory tests are all normal, and then you have radiological tests which have been done, which can go for anything from CT scans to high-tech imaging. And they have been shunted from a cardiologist to a respiratory physician to a general physician, and still you are nowhere with a diagnosis or treatment. And I'm not I'm sure this is also done in India, but in the UK, if you go to a general practitioner and you get breathless, they will just prescribe an inhaler and say, try it and see. The good thing is it works in a lot of people, but there are lots of people it doesn't work in. So it's useful to keep this in the backs of our minds. So in the next 15, 20 minutes, I will briefly look at these five things. First, look at the systems causing shortness of breath and what are you going to be looking at. That'll be the first thing we look at. The second thing is to discuss the differential diagnoses. What are the things that you can pick up, um, or what are the things that you would keep in mind when you think of unexplained breathlessness. And thirdly, we won't have time for all this, but I will just mention these things because each of these are topics on its own. What are the diagnoses which are unique to cardiopulmonary exercise testing? Meaning, what are the things that you can pick up just by cardiopulmonary exercise testing, which you might not pick up by some of the other tests that you do? Then I think it's useful to look at a paradigm, a sort of a guideline. What would be your plan? Who should you test and how you do this? It's useful to have a paradigm. I'll just say very briefly about that, and I'll just illustrate two cases, which will just give you an idea very briefly about how this can help in our. It is one of those big things that we have in our diagnostic armamentarium. You can use it, and how can you use it effectively? So that's the plan for the next 15 to 20 minutes. Um, all of you have done the physiology bits. You must have seen this ad nauseum. You have seen this. Carl Wasserman and his team developed this cogwheel system where you have the muscle, you have the heart, and you have the lungs, and how they all work together. And that's very important because what we are doing when we do cardiopulmonary exercise test is you're not testing a system in isolation. You're testing the whole system, as in every system working together. And then you get an answer out of this. And these are the three big names. As you know, all of them are dead now. Carl Wasserman, Brian Whip, and James Hansen. And I had the great privilege of training with all of them over the years. And some of the things that I've learned from them have been invaluable. You did this before, but just the same cogwheel. If you look at it from the left, going to the right of your screen, you have your lungs, which you breathe. You have the gas exchange happening at the alveoli level, and then the blood goes into the heart. You have the oxygen transport going across to the peripheral systems. You go across to the end organ where you have oxygen extraction. So you have BO2, which is the oxygen consumed, and the BCO2, which is produced. And this is what we're really talking about. And the whole idea of doing this test, you've looked at the indications, I presume, or maybe you haven't, or you're going to do it at a later stage, is to see what system is involved, or if any system is involved at all, or what are the contributions of the various systems causing the patient's symptoms. So that's basically what it is. And I've just showed this plot because, as you're aware, there are various different plots which you can get the 9-panel plot, which is this is the original 9-panel Wasserman plot, which is what I will be using. As you know, over the last 5 years, they've got a slightly reoriented plot, and those reoriented plots basically look at the cardiac on one side and respiratory and ventilatory on the other side, and a few others at the bottom. But I'll be looking at the original ones because I'm used to this, and those are the ways it is numbered. We won't go into all of this, but just assuming that people online would have some idea of what are these various plots and how they are measured and what it tells us. Obviously, in this 20 minutes, we will just cover the systems which are happening. So if you think about it, the easiest way to think about it is to think of three big system limitations. And the first system limitation I would propose is you look at the cardiovascular limitation. So what are the things in the cardiovascular symptoms which can limit a person's exercise capacity and thereby making him or her breathless. So, this I'm sure you covered the last time. You have what is the oxygen consumption is basically the AV difference and the cardiac output, which is what we all learned in physiology many, many years ago, the fixed equation. And you can translate it to the stroke volume and heart rate and your hemoglobin, absolutely important for the transport of oxygen as well. So when you look at the 9-panel plot, I think the first thing to ask yourself is go to a summary plot. Whenever you interpret CPET, go to the summary plot. And I would propose that this plot 3, which is looking at VO2 and the VCO2 and the load, which is going up, as you can see in the green line going up. The VCO2 here is in red and the VO2 is in blue. So you need to be careful about your scalings and all that. It is a very good summary plot and it will give you an idea of overall what is the picture. And when you asked the question about cardiovascular, I propose the other two plots you need to look at is plot 2 and plot 5. So what are we looking at? Plot 3, which is the reference plot, as I said, you're looking to see what is the VO2. In this case, the VO2 is actually in red. You want to see if the patient reaches your predicted VO2. You look at the peak and you want to see when does the patient shift from aerobic to anaerobic metabolism. As you're well aware, and I'm sure you discussed last time, there are various kinds of thresholds, but we'll just call it a threshold today when you switch from aerobic to anaerobic. And I'm sure you looked at what are the various ways you detect how this transfers from an aerobic to anaerobic metabolism. So to summarize, if you look at plot 3, the things that you're looking at overall, which gives you a broad picture, is you'll find that the peak VO2 is not in the expected range. It is decreased. And the second thing you look at is the VO2 work rate slope, which I'm sure you discussed last time. This is the green line is the load, and this red line is the VO2. And normally you would expect them to be parallel to each other. And if the patient is fit, they would diverge. If it converges, which is what appears to be the case, as you can see, there are lines extending. That looks like they're converging. They're not parallel. You know that there is something going on, and it could be a system limitation. This is the overall picture that you would pick up. And when you look at any other limitation, plot 3 is the core. Okay, so those are the two things for cardiovascular limitation, which you will see as will be the case for ventilatory limitation and BQ mismatch and a few other things as well. But that is plot 3, which is core for everything. Then when you look at plot 2, what you're looking at, plot 2 is looking at the oxygen pulse on one side, and you're looking at the heart rate. So you're trying to see if the patient reaches a target heart rate early. As you all know, we've studied in our exercise Bruce protocols. If you get target heart rate very early, your cardiovascular system is not as good as it should be. So that we all know. But when we plot this along with the oxygen pulse, you will find, first of all, the oxygen pulse may be flat, meaning it does not rise adequately along with exercise. And what is the oxygen pulse? It is very simply the VO2 divided by the heart rate, which means per beat, the amount of oxygen consumption is not very good. So that is the oxygen pulse, which can be flat. And the second thing is your heart rate can be very steep. So normally you would expect it sort of parallel, but when you find they are significantly divergent, oxygen pulse and heart rate, that gives you an idea in plot 2 that this patient has a degree of cardiovascular limitation. And finally, you go up to plot 5. So you're all adding up all the values as we go along with each of the graphs. And this plot 5 is basically looking at the VO2 and the VCO2 and the heart rate. And as you can see, your heart rate, there is a steep rise. This is what you would expect the heart rate to be within those two red lines. If you find that heart rate VO2 slope is steep, then you know that the patient is using not stroke volume, but they're using the heart rate to increase the cardiac output. And that is a classic feature that you would see in any cardiovascular dysfunction patient. And also your VO2, as you can see, the VO2 at the anaerobic threshold is going to be reduced in these patients. So overall, when you look at plot 3, plot 2, and plot 5, you would find these are the things which tell you this patient is probably got a cardiovascular limitation. So that is peak VO2 is decreased. You find that the VO2 work rate slope is, it's shallow. Early anaerobic threshold, which we know, I'm calling it anaerobic threshold. You can call it whatever you want. It's early. There is some disease which is happening. Peak heart rate and heart rate response, flat oxygen pulse, the slope we talked about. We can also have a few other things which I haven't mentioned, looking at other graphs. The ventilatory equivalence for carbon dioxide, which is in plot 6, which will be elevated, which simply means that your ventilatory efficiency will also change when you have a cardiac limitation. In bad patients with heart failure, you may also find that the VE is oscillating. You can have the changes which can go up and down. And obviously, we all have an ECG running side by side, and that can give you ideas of ischemia, whether there's inducible ischemia during exercise. So just putting it in perspective, this is a normal on the left, and you have the cardiovascular on the right. As you can see, the VO2 oxygen, as you can see, this is the VO2 goes up nicely there. It's sort of not reaching the bit, and it's less than 10 VO2 work rate slope. You find that here the heart rate going up nicely, but it's going up pretty quickly here. Oxygen pulse goes up, it's sort of flattened. And as you can see here, you see your heart rate steep slope. So that gives you plot 3, 2, and 5 tells you there's an indication. And as you do the test for this patient, you will find that things change. So that's the first thing. The second thing is limitation in ventilation. As you are all aware, ventilation is I always ask my medical students, where does the respiration take place? And they talk about the lungs. Respiration is at the mitochondria, but ventilation happens here. You have the gas exchange, you have the transport, and it goes across. We're talking now specifically about ventilation. And I'm sure you did this before. You have the ventilatory capacity on one side, and then you have the ventilatory demand. And then when you talk about capacity, you're talking about your MVV, which I'm sure you did last time, maximum voluntary ventilation. You can calculate it, and you can also do it as a maneuver. And then what is reached, you can see the V demand. It's not moving. Okay, so just saying some of the things which you must have already looked at, which we, when you look at the ventilator demand completely increasing, you find that your peak ventilation approaches MVV very quickly, and then that results in a peak VE, which you're getting during the test is it's more than 85% of the maximum voluntary ventilation, which means your breathing reserve, that's what you're trying to get at, I'll show you in a minute, is reduced. So what are the indices that you're looking at? Obviously, plot 3 is always important. You keep that in the back of your mind, but plot 1, plot 4, and plot 7. And what are you looking at here again is the breathing reserve. You're looking to see what is the minute ventilation. Minute ventilation is going into the accepted range, and you don't have what's called as a breathing reserve in these patients. We're running short of time, so therefore I'm not going to explain it in detail, but you're looking at the ventilatory ceiling, and you're looking at the breathing reserve less than 15%. It's the usual ballpark figure which I give my trainees, and they can use it for their specialty exams and so on and so forth. And it's a good thing that we use all the time. There are lots of caveats. Can there be conditions where the breathing reserve is less than 15% with no disease? The answer is yes. We don't have the time to discuss it, but there are lots of caveats. So what you're actually assessing is in plot 4 again is the VE and the VCO2 slope, and see if the efficiency is higher. And that is where you would expect it to be. And these are the conditions where you can get your slope to come below or above the accepted line. And this is what I'm trying to say. You're having a high slope in panel 4 where you have V by VCO2, meaning you're trying to say the amount of breathing is much more for the amount of carbon dioxide produced. So what you do in plot 1 is you assess a breathing reserve. In plot 4, you find if there's a higher slope. And then you find in plot 7, we haven't spent much time, we can look at the change of a tidal volume with respect to V in plot 7. But that's a minor point. But really, you're looking at the breathing reserve and looking at the higher slope of the V as compared to the VCO2. So that gives you an idea of, as you can see, those are the three plots. You're looking at 1, 4, and 7. You can find that the V is up there. You find the plot is higher, and then you find as you can see, the tidal volume also goes up, but the V is significantly elevated. So those are the three plots you would use for ventilatory limitation. And the third limitation which you need to look at and ask yourself, is this the thing which is causing problems? You will note that I have mentioned cardiac limitation, ventilatory limitation, and BQ mismatch. I have not given you specific conditions. I'll mention it briefly, but there are lots of things which can fit into each of these three brackets and some which can overlap, as I'll show you in a minute. I would say the main plot is plot number 6, where you look at the V by VCO2. You may look at plot 4 as well to look at the steepness, and plot 9 to look at the end tidal carbon dioxide, which we will touch very briefly. So I don't know if you've done it last time, but there are two things you can look at: that actual value of the V by VCO2 in plot 6, or you can look at the V by VCO2 slope. Basically, a magic number I normally give my trainees is 35. And if you have anything more than 35, then you think of something which is going wrong. So that's the VVO2 number and the VVO2 slope, both of which you can get in panel number 6. So basically, VVO2 is more than that. The slope is more than 37. End tidal in plot, if it's going to be very low, then you're thinking of patients with a BQ mismatch. So this is what we are actually looking at. This is a normal V by VCO2 here, and you can see a very high VCO2. That is the crucial point. And obviously, plot 4 will also have other changes in ventilation, which will accompany problems with BQ mismatch. Why do we mention VQ mismatch separately? Because there are conditions like pulmonary vascular disease, which affects predominantly VQ mismatch as opposed to ventilation. And as I said, that's how it looks, and that's how it would look in the abnormal. So we looked at the three systems and what are the plots that you look at. And you're coming back to the same patient who had this. You had the scenario with breathlessness. You gave all this. It's important that we all have these issues. You have the baseline tests, resting tests, all of them are normal, but the patient is dyspneic, and the patient wants to know what's wrong with them, and which is why you would want to use CPET. So very briefly, what are the possibilities? I'm sure you know all the answers, but I'm just putting it down here. Things like diastolic dysfunction, which the cardiologist sometimes says that it's part of age, but no, there is a problem. You can have normal ejection fraction heart failure in patients. You have anxiety, which is rather a common case. You can have shunts. We do a lot of patients with adult congenital heart disease in our center, with looking at shunts and how do they perform. In this country, at least, people look for benefits. You have obesity, you have deconditioning. All of these are topics on itself, but I'm just mentioning it. But I think it's very important for us to know a little bit of this and a little bit of that. And I think Barney is going to be answering some of the questions about the interaction. So you can have a combination of things which can actually add up or make the patient more breathless in the end. Just mentioning some of these things, early coronary ischemia is a very, very useful thing. And plot 2 is something which I think is absolutely important. There have been cases of patients, don't have time to discuss it, but case of patients we picked up very early who have had significant coronary artery disease. particularly going for surgery, who did very well because their coronary ischemia was fixed first. Pulmonary vascular disease, very important. We look at patients with chronic thromboembolic pulmonary disease, embolic disease, hyperventilation, and other dysfunctional breathing problems. You can have pattern disordered breathing or breathing pattern disorders. As I said, heart failure with normal ejection fraction, shunts, deconditioning, obesity. So, if you have a patient, it's usual to have a paradigm. And I put this here because I think it's very important. You do a CPET test. The first thing you do, you ask yourself, what are you doing it for? Do you have the diagnosis already? If you have the diagnosis, you're wasting your time, unless you're trying to look for something else which is unexplained. So you don't want to do it for a BUND or COPD or ILD, which you have the answer elsewhere. So that's the next question. Is there an obvious diagnosis? Clinical examination, does it give any clues? Resting tests, are they normal? Then you're trying to see if you can identify a system, and that will direct you to further investigations. As I said, you will be able to get a system, but you won't be able to pinpoint the problems, because if you look at studies which was done in 2019, there are a variety of things. Hyperventilation, a fifth of them; deconditioning, about a third of them; cardiovascular is very small because there are other tests that you can do. Submaximal tests, which means the patient is probably even deconditioned. So those are the questions that can be answered in a standard CPET. And then if you sort of put gas exchange, and if you put um, oxygen transport and ventilation, you will find that you can put a number of conditions. So I'm not going to be talking about this, but as you can imagine, there are a lot of conditions that you can talk about as well. I would say when we looked at our cases, obesity was one of the big things. It was published in Thorax. You had mixed cases, you had deconditioned, but mainly obesity only a fifth of, which is a third of patients. And obesity as a contributing cause was 22%. And there are a number of reasons for that, because the patients, because of obesity, have got a normal heart and lungs and muscles, but they stop earlier because they have to carry that extra amount of weight. So CPET can help reassurance, dietary advice, and obviously exercise prescription as well. I put this slide up because there are some things that CPET cannot usually answer. Sometimes it'll be difficult. Hyperventilation versus pathology. And I think one of the questions you've asked me to say, I'll mention it, but hyperventilation versus pathology sometimes can be difficult. Lung volumes, when they change, we know the principle of dynamic hyperinflation. Can you pick it up unless you do loops during the exercise? Probably not. Sometimes it's difficult to say which is deconditioning and which is disease, because they can overlap, or they can both can be present. There can be problems with oxygen extraction. You can have problems at the myopathic level. Unless you do post-exercise flow volume loops and spirometry, you will not be able to pick up exercise-induced bronchospasm. And sometimes you might find dynamic upper airway collapse, might be difficult to pick up. So I'm not saying you cannot answer it, but it may not be answered in these patients. So the points to note is a patient can have disease in more than one system. Always keep that in mind. And therefore it can have limitation. You may have disease, but it may not limit, but you can have limitation. And your job and my job is to figure out what is the predominant limitation, to see if you can tweak the treatment. Use a systematic approach. This 20 minutes is not enough. CPET is a big topic, but I've tried to do as much as I can in the 20 minutes. I would always suggest you have somebody to bounce your answers on, which means, can you talk to somebody and say, am I doing the right thing? A colleague to corroborate. And my other big message to all of you is keep reporting, and more reporting, because you would see you cannot learn it in theory. It has to be done to get answers. I don't think I've got time for the scenario, so I'm going to stop here. I was just going to show you a patient who had, we can do it at some other time. Because we don't have time, I probably will stop here if that's okay. So I think I've looked at limitations causing system limitation, looked at some differential diagnoses. We looked at some diagnoses unique to CPET and looked at the paradigm. we did have time to do case illustrations, and I will hand it over to Supraja Supraja for the further questions. Thank you.
Thank you, sir. That was a very lucid presentation. And as you said, in 20 minutes to do justice to an unexplained dyspnea is extremely difficult. Of course, but we handed it over to you because you are the expert and you put it in a beautiful nutshell for the audience. We'll now move on to the panel discussion. Can I have the panel introduction, please? So we have a 5-panel discussion. So we have Dr. Thilagavathy. Ma'am is MD and DTCD. She's a HOD and senior consultant, respiratory, sleep, and interventional pulmonology from Vijaya Group of Hospitals. She has many achievements to her. She has been the treasurer and co-founder in Women in Pulmonology. She's the associate editor of Pulmonary Disorders in Women, faculty of the NAPCON and TAPCON, member of many national board for the National Board of Sleep Medicine Fellowship, and she's been awarded Inspirer in Pulmonary Medicine 2023 by the ICS. Notable publications is on rare lung diseases like tracheal bronchus talcosis, a case of pulmonary maltoma camouflage within invasive pulmonary aspergillosis, and community contribution has conducted and has been a faculty in workshops in NIV, sleep, PFT, and bronchoscopy, and a passionate PG teacher and part of free asthma camps and respiratory awareness programs. We next have, next slide, please. Dr. Lieutenant Colonel Dr. Manu Chopra. Sir is from Armed Force Medical College, Pune. He is a professor and HOD of the Pulmonary Medicine Department. And his major interests are in interventional pulmonology, especially navigational bronchoscopy, bronchoscopic management of post-intubation and tracheostomy, tracheal stenosis, cryotherapy, and electrocautery. Difficult to treat asthma, orphan lung diseases. Publications and book chapters are National 45 and International 60. And he is reviewer of many journals such as JAFFE, PLOS, Chest, Thorax, ERJ, and Lung India. Next, please. Next, Dr. Ruchi Dua. She is MD DNB and EDRM. And she is currently professor at AIMS Rishikesh. Ma'am's areas of interest are in airway diseases, PFT, NIV, EBUS, and interventional pulmonology. Presentations around 30, publications 50, awards 3, distinction in biochemistry and second Young Scientist Award in NAPCON 2017 and Best Paper NATCON 2022. Fellowships and memberships. She is in UK ICS and ERS Fellow and WABIP. Not the least, Dr. Barney Issac. All of us know him. He is a professor and head at the Department of Pulmonary Medicine, CMC Vellore, and he's a consultant since 2009. His areas of interest are in ILD, particularly sarcoidosis, biostatistics and study designs for the clinician, exercise physiology, sleep disordered breathing, interventional pulmonology. His publications are 59 and book chapters 1. Conference presentations 30, reviewer in 5 index journals, awards Young Scientist Award NAPCON in 2008, and Best SAS Trainer Award UK 2014. So this is the lively panel that we have today for the great discussion that you're going to have.
Can we have the next slide to introduce Dr. Supraja? So it's my privilege to introduce Dr. Supraja. So I've known her as a very dynamic person who got connected with me because of CPET, actually. So she's the managing trustee and lead consultant and director of Medway Institute of Pulmonology. Very nice place to go and see around. Even the lifts are all filled with pulmonology pictures in her hospital. Her areas of interest are actually rehabilitation and predictive medicine. She does research in genetics, lung organoids for transplantation and sleep medicine devices. She's won numerous awards, including the oral presentation on VAP in cardiac surgery at Seoul, the URS Young Investigator Award in Hanoi in 2019, the SN Gaur Young Scientist Award at NAPCON, and the P.S. Shankar Award for Innovative Research in 2016 in NAPCON. It's a pleasure to have her as the moderator for the discussion today. Back to you, Dr. Supraja.
Thank you, sir. We will start off the discussion with Dr. Ruchi Dua. And then, because we are assigning specific topics like last time, unexplained dyspnea to Dr. Ruchi Dua and Dr. Johnshon. And then we'll go on to high altitude and super health individuals to Dr. Manu Chopra and complex cardiopulmonary to Dr. Barney. So starting with Dr. Ruchi. Ma'am, so how do you integrate CPET findings with symptoms when the reports are looking very, very borderline or mixed rather than clearly abnormal?
So, see, the clinical history is always a very vital part. And as already has been discussed, rather than focusing on any isolated variable in the CPET, it's always better to have a syndromic, like whether it is going to be ventilatory limitation, or is it a cardiovascular limitation, or is it something which has affected the gas exchange. Having still said that, as already has been discussed by Sir also, that a disease can involve multiple systems, and vice versa is also very true in this. I would just like to give an example, like in one of our patients, the computer generated report was giving based on the heart rate recovery that it is possibly a case of cardiovascular limitation. But when we discussed the case, actually the oxygen pulse was not showing a plateau and was not showing the required, which is required for cardiovascular limitation. So there we finally interpreted as that there is not a significant, it does not appear to be a significant cardiovascular limitation. So we shouldn't rely on any one variable, rather go for the syndromic. And the pretest probability also plays an important role. I'm fortunate that I share the topic with Dr. Johnson, and where Sir wants to add on something, he can definitely add to that. Yeah.
You're spot on.
If it is the case, then we'll move on to the next question to the audience. We will first round finish in the initial 3 rounds. We'll ask questions specifically to the panelists, and then I'll take up questions from the audience to Dr. Thilagavathy on preoperative indications for CPET. So, which CPET variables are most meaningfully changing the perioperative decision making in high risk surgical patients? We are talking specifically for thoracic surgery patients.
So thank you. Good evening to everybody. Thank you, ICS and Dr. Amita, for arranging so much of academic activity. Thank you for having me as a panel here. And that was a wonderful talk by Dr. Johnson Samir. Though we did not, he had no time. I wish he discussed the cases. So if there is time, I think we should permit him to do that, because I'm also looking forward to that. Okay, so the preoperative assessment, I think, is a very crucial step in a patient whom we are planning to have a lobectomy or a pneumonectomy, because it offers the best long-term prognosis in a specific patient. At the same time, surgery cannot be offered to a patient who is expected to become ventilator dependent postoperatively. Hence, it's very important that we have a proper objective preoperative assessment. So pulmonary resection as such is a little bit of high risk surgery, even in otherwise normal healthy individuals. So preoperative prognostication and optimizations are very, very important. And it's also very vital to establish that patients will tolerate lung ventilation intraoperatively, that is one lung ventilation, and will have sufficient reserve postoperatively. So as far as preoperative assessment from ERS, ATS, and ACCP, all that. So the one basic thing is they follow 3 steps. The main first step is, of course, you have to identify your patient whether he has a high cardiac risk. He's a cardiac patient, known cardiac risk, straight away go for CPET. If not, again, we have to, the step 1 is our regular PFT and your spirometry, where in step 1 you perform a spirometry, perform your DLCO. So the baseline function, if there is a we are not going by absolute values like what we used to do previously. Now it is like post-operative predicted value of FEV1, post-operative predicted value of DLCO. So if your initial, both are mandatory, which is very, very important. You cannot do one and leave off the other one, because both have important function, as we all know. So if your post-operative predicted value of FEV1 is more than 60 and your post-operative predicted value of DLCO is more than 60, straight away you can give the fitness for the surgery. But if your patient is having an intermediate risk between, and if your risk is less than 30%, then he carries a very high risk. If somewhere in between, then you go to CPET. So CPET is like, as sir mentioned, you can have a cardiac component, you can have a respiratory component, you can have a circulatory component, you can have some anaerobic threshold muscular component, and you can have a combination this and that, and he explained so clearly. So you can have a mix of everything. So you need to really assess. But as far as pre-operative assessment is concerned, with all the 9 graphs, the VO2 is the one thing which the guidelines recommend. So VO2 is a single important parameter as a direct measure of exercise capacity. CPET assesses everything, but in your VO2, if you have a patient who has more than 75% predictor or more than 20 ml per kg per minute, then he has a low perioperative risk. You can straight away give a fitness for him, even if it is pneumonectomy. So if your patient has between 10 to 20 ml per kg, he carries an intermediate risk, and it's an individualized decision. In such cases, again, the CPET will tell you, the other parameters will tell you what is his actual problem. Is it cardiac? Is it pulmonary? Is it circulatory? That's a combination of everything. Try to address, optimize this, and then subject him for a risk and assessment. If your patient has less than 35% VO2 peak or less than 10 ml per kg per minute, he carries a very, very high risk. So this patient usually may be inoperable. You should look for non-surgical options. If your patient has some option of radiotherapy and other things, you should subject him to that, and at a later date, we can reassess him. So the most important thing is all the other parameters which he mentioned, all are important. We see your heart rate, breathing reserve, everything is important. But for preoperative assessment, only VO2 is fair enough. But there is a slight, ACCP has one slight modification from this. So they usually low technology exercise tests they have. If you can't go from the first step to the CPET, then they say you can use a stair climbing test or a shuttle walk test. And if your reserve is very good, straight away give the fitness. In a special case where you don't have a CPET.
Okay.
But ERS and ATS are very clear. If you have a cardiac risk, you have to go with the CPET only.
Beautifully said, ma'am, because we have a huge chunk of postgraduates who are attending this webinars. So it is a good information for them for their exams as well. Dr. Manu Chopra, you are a specialist in doing it for super health people, like, people who are going to high altitude and in scuba. So how do you use CPET to differentiate between the physiological limitations in a patient who is clinically and, athletically, if he's fit? How do you identify subtle findings that you do identify?
Thank you, Dr. Supraja, for asking the question, also for inviting me on this panel. I'm grateful to ICS and Dr. Nene for giving this opportunity. Now, all said and done, the question is very complicated for me. It's not the patient, they are the individuals. They are healthy individuals who are clinically, radiologically fit. The test which you are carrying out day to day to assess any individual. So these are the soldiers or the officers who have to be posted or who have to go to high altitude areas, means something more than 9,000 feet. They have to go to guard the borders in from J&K up to the Arunachal. And of course, we have a long coastline. So we have a good naval command also, wherein they have to go for scuba diving. So these all individuals have to be fit. At any point of time, 70 to 80% of these individuals are in these areas. So how do I say that they are fit now in this peace area, fit in Pune with me, but will he be fit in Siachen? So, of course, these are not the patients. They have to come to us for their assessment. We can't go and check 1.2 million standing in an army and do CPAT for all of them. And I can't be lucky enough to choose at only one part, that VO2, that I use only VO2, and I can say that no, the VO2 is low now, this individual is fit. So I have to do CPAT, which is an integrated performance system to assess lungs, heart, circulation, skeletal muscles, everything it can assess. But of course, I have to see all those charts, assess, find out every fault in this. So these individuals, what I see in my practice, firstly, I do a ventilatory inefficiency. That is a V by VCO2. If that line is rising nice, the individual is good enough. The ventilatory efficiency is good. The amount of carbon dioxide produced, the amount of respiratory ventilation which is taking place is adequate. Individual is good. He does not have any ventilation perfusion mismatch. There is no increased physiological dead space. There is no early pulmonary vascular disorders, no early interstitial lung disease. So these things I can assess from CPET. Similarly, the oxygen uptake. like reduced peak VO2. It may plateau early in our patient. The individual may be fit in normal areas wherein the normal exercise he may be able to do everything. His peak VO2 will be normal during the routine exercise, but as we increase the workload, his peak VO2 may fall down. So it indicates that there is a global deficit in oxygen delivery or utilization. So it's not only the lungs, it may be the vasculature, maybe hemoglobin, or the muscles which are not able to extract. So it just gives me an idea the individual is not fit enough. There is some pathology going on. I have to assess the pathology subsequently. Now coming to it, as Dr. Johnson had told, the most important system, the cardiovascular system. So again, O2 pulse. If there is a flattening of O2 pulse, as it's beautifully shown in these graphs, so there's a flattening of O2 pulse. This individual has got some amount of unmasked cardiac problem. It could be a preserved heart failure with a preserved ejection fraction, early cardiovascular disease, which is not manifesting as and when he's doing his routine exercises. It can also show me an early anaerobic threshold. Now we check that also in anaerobic threshold because as I said, I have to see all the graphs of these patients. So in a low workload, if the individual is able to achieve the anaerobic threshold earlier, that means that the individual, if I put him under stress in a high altitude areas where is already there going to be hypoxia, the strenuous exercises are going to be there, or in a western sector in deserts, if this individual is going to work, he is going to get fatigued earlier, he is going to fail earlier. So CPET gives me that armamentarium wherein I can assess an individual who looks fit, but is he physiologically fit, to give him that higher workload to see if this workload, if he is able, these all the organs are functioning well. So it is a good tool for us and we are using it judiciously as of now.
Wonderful, wonderful. So we understand that even in super health individuals, I mean, I'm putting it as super health because unless you undergo rigorous selection criteria and then training, and in those patients, again, people again, you are finding some limitations, which at least help us to segregate or select the fittest of the fittest to be posted in the most critical areas. So wonderful. This is one area which is very, very interesting. And I'll move on to Dr. Barney. Sir, this is the most biggest chunk that all of us get, mixed cardiopulmonary diseases. So how do you identify? So you're having both cardiac and respiratory. Now, how do you define or understand which is the most dominant system, which is producing the breathlessness in this current patient?
So thank you, Dr. Supraja. And I thank ICS, Dr. Amita and team for giving me this opportunity. And I also take this opportunity to thank Dr. Samuel because whatever I know in CPET today and practice, I owe it to him in the 2 years I spent in Basildon. It's more than a decade back, but it still continues to help me in my practice. So thank you very much. So first of all, I would just like to say that, when a patient comes with dyspnea, you do not know that more than one thing is happening with him. That's a problem. If you knew that, you wouldn't be doing a CPET. You have a patient who has unexplained dyspnea, who may have one or more than one. That is the situation we are dealing with. And this patient is going into exercise. And that is why this test is so superior to all the static tests like spirometry, even advanced lung functions or echocardiography, which is unable to pick up things that happen with exercise. Now, when you do exercise, we need to understand that the patients stop the exercise, and we are trying to find why the patient stops exercise. Now, when the patient stops exercise, there are 3 reasons why a patient stops exercise. One is because the patient is out of breath. Second is because the patient becomes fatigued. He's not able to go on any further with the increase in load that is planned on the CPET. Or third, there is leg pain or legs are giving away. So it's very important to capture the reason why the patient is stopping the test. Because, for example, sometimes patients who have cardiac dysfunction would become more fatigued, or they may have fatigue and breathlessness together. So that may be one important starting point. Secondly, when the patient stops or stops the test because of fatigue or breathlessness, the parameter that has begun to manifest itself first in the abnormality is the system that is limiting the exercise. So once we understand this, it's pretty straightforward. We just learned that for example, and if you look at each system, there is a predominant aspect. For example, if you take in all of them, the VO2 will be low because they are not able to achieve their VO2, and that is why they are breathless. The demand that the body produces during exercise is not able to be met by the combination of various systems or a particular system which is failing. Now, the next step to look at is which system is failing. And we saw beautifully, like, for example, if you take the ventilatory system, the patient will run into his MVV, which means the minute ventilation or the ventilator equivalence will be so high that he will not have any reserve left to breathe further. So that will be the predominant manifestation on the CPET. If you look at the cardiac dysfunction, you would have a response of the oxygen pulse, which is probably the main parameter that goes flat because the normal response, which is the stroke volume, which increases, is not able to sustain itself, either it be systolic dysfunction or diastolic dysfunction of the left ventricle. In either situation, after a point, it's not able to pump. So the heart rate tries its best. So the heart rate peaks, but the pump is failing. So the VO2 by heart rate flattens out, and this leads to a early achievement of the anaerobic threshold also, because you are not able to pump oxygen into the muscles to be able to participate in the peripheral respiration. I mean, the other thing that confuses in this bit is also pulmonary vascular disease, because again, that's something, although we just put down ventilatory and cardiac, the pulmonary vascular disease actually manifests primarily by a very early peak increase in the V by VCO2 slope, because there is a lot of wasted ventilation that's happening. The physiological dead space is going up because the blood supply to the lung, for whatever reason, is not able to match the demand. There's a lot of wasted ventilation because of that. So that is the primary parameter that goes up. So if we find out the cause for the stopping of the test and see which of these primarily manifest, we will be able to pinpoint the important system that is limiting exercise, and then it helps us to address that part of it in the treatment.
Wonderful, sir. Beautifully said. To Dr. Johnshon, sir, so I have two questions for you. I'm taking it from the audience. It's very nice. What is the first important question you ask in a patient with dyspnea? That is part A. And part B will be, I know you have summarized all these, but what are the standard investigations like a PFT, echo, everything is normal. So what CPET patterns reliably distinguish true physiological limitations from perceived breathlessness? So you're on mute. Sorry, you're on mute.
Sorry, the first question is, what is the question that I would ask the patient? Is that what you're asking?
Yes.
Okay.
Yes. The first question, most important.
Okay, so dyspnea is an interesting thing. What is dyspnea? Dyspnea is basically a perception of breathlessness. Isn't it? It's an uncomfortable sensation of breathlessness. That's what dyspnea. So dyspnea for you and dyspnea for me may be different. I might be Manu was talking about super fit athletes, super fit people going up Siachen and so on and so forth. So for the super fit athlete, a normal CPET will be abnormal. So I do some triathletes who are athletes who do all sorts of swimming and running and cycling. So they are usually super fit, and their peak VO2, for example, some of them will be in 48, 50 ml per kg per minute, as opposed to the 25 to 30 that you would expect in the normal age group, or even 35. So for them, if it comes down from 50, let's say, to 40, they may be limited. That's something you need to be very important. So the question you need to ask yourself is, what can't you do now what you could do before? Okay, so if there is one question that you need to ask is, what can't you do now that you did before? So you may have been able to walk 5 miles, say a year ago, I'm able to walk only a mile now. So there is a significant difference. So that's the first thing you need to ask. And the second thing is, along with that, you need to ask or make an assessment of this person's overall fitness as you see it. So the first one is the subjective thing the patient comes across. Second thing is objectively. If you look at somebody who's 85 who says, I can't do 5 miles, it's time for you to tell them you're 85, don't do 5 miles. Okay, so I'm just using an not being ageist or anything like that. But what I think is your objective view of the patient. So that those are the two things you may want to ask and you want to assess in your mind. And the third thing as well, which our physiologists are very good at doing, is never forget to ask what medications they're on. Because there are some drugs which can quite significantly affect people, which we won't go into now, which is very useful to get. And it's also useful to get that when you do the CPET, because there are lots of patients are on beta blockers. So your heart rate response and other things can change. And we never ask them to stop anything when they come for the test. So that would be the first question. Does it make sense?
Yes, sir.
Okay. The second question is, you said, what distinguishes true physiological limitation from perceived breathlessness? So I think there are four things you need to think of. The first thing is, we always do the Borg dyspnea score. I presume everybody does that, a score of 0 to 10. So we ask the patient right at the beginning what the Borg score is, and at the end what the Borg score is. Okay, so it's very useful to know what it is. And we always tell the patient that whenever you exercise, I'm going to beat you till you fall apart, which means you need to give it a very, very good effort. And you can I always, or rather, our team always tells them that we have every marker in front of us, which will tell us that we will stop the test if we think something is abnormal. But at the same time, the patient is the ultimate person who can stop. So if the patient says they cannot do it any further, we stop it. And we say the two important things are Barney knows this, we ask them to point to the chest or point to the head. You can either become dizzy or you can have chest pain. Breathlessness, you can see it anyway, and they'll say they stop. So that's the first thing. And when you do a Borg score, and then when you see that the patient is not limited on your objective findings, a patient's got a Borg score of 10 and you find that the patient has VO2 which is even 30%, and nothing has happened, patient has not reached threshold, that there is a discrepancy. Okay, that's the first thing. The second thing is, when the patient says, I'm totally out of breath, Borg score is whatever it is, and it's a submaximal test. Okay, so that the patient has not exercised and reached or switched from aerobic to anaerobic. Very clearly then this is more of perceived breathlessness than for anything else. The third big thing really is your what we call as breathing pattern disorders or dysfunctional breathing, which includes hyperventilation or laryngeal dysfunction. All those things come under that. And you can see your values are absolutely normal, but you can see either the rate is going up or the pattern is changing. Okay, so then it's physiological or not physiological. And the fourth very big thing is obesity. An obese patient, you need to know that there's a normal heart, lung, and whatever is inside, but your exercise capacity has come down because all your graphs are pushed upwards. So obesity is a pathological, well, it is a problem, or rather it is a pathological problem, but that can cause early limitation of exercise. So obviously, if we talked about the system limitations. If all of them are there, there's a system problem. But when you look at the symptom of the patient and looking at when do you say this is system problem, when do you say it's functional, these are the things, these are the four things I think you would want to look at. There are lots more, but I've just put four things.
Yeah, to keep it simple and to remember as well. Yes. Dr. Ruchi, so you have a lot of experience with exercise-induced bronchospasm, and your specialty, one of your specialties is also doing CPET in such patients. So can you elaborate us more on that aspect as well?
Thank you, Dr. Supraja. So we have CPET can also be used for performing an exercise challenge test for that matter. And as was also mentioned in the talk, that in that scenario, CPET has to be followed by repeated FEV1 maneuvers, which are to be done at required time frames, like 5, 10, 15, and 30 minutes to detect it. So we have the baseline FEV1 values before we have performed the CPET. And after the performance of CPET, we can have the FEV1 values. And we can also look at the flow volume loops even while performing the test for that matter. We don't have it in our CPET machine for some reason. So what we usually do is performing it after we have done the CPET. So we compare the baseline FEV1 and the FEV1 in the repeated maneuvers. And if there is a more than 10% fall, then we can say it to be a case of exercise-induced bronchoconstriction. So it can be one of the exercise challenge tests which can be used to make a diagnosis in these scenarios.
So if you would like to elaborate more, so we have other exercise-induced, other challenges for bronchoconstriction. So when would you choose a CPET? And if at all, why would you do that?
So very first, if you have a clear-cut case of asthma, so then you already have a proven bronchodilator responsiveness. Then you do not actually need to undergo a CPET for that matter. So this question of performing this test would only arise when you do not have a documented bronchodilator responsiveness and you do not have a definitive diagnosis, is one thing that is to be emphasized. Then in many centers, like we also do not have the bronchial challenge test for that matter. In a patient where we have tried to demonstrate the bronchodilator responsiveness in multiple visits and we have not been able to do it, so that is a scenario where we can opt out for it. And we do not have the bronchial challenge test, so this is one, or an individual who is reporting exercise-induced symptoms for that matter can also be a candidate for performing these tests. So as we already know that EIB can occur with asthma and even without asthma. Audible? Yeah.
Yes. Yeah. We now move on to the preoperative topic to Dr. Thilagavathy, ma'am. Ma'am, so how will the results of a CPET influence your anesthesia planning rather than just a surgical clearance? So do you give an input to your anesthetist as to how long the surgery can be, or what is the type of anesthesia that they can do? How can this be useful?
Yeah, so that depends on the type of surgery you're going to do, whether it is, segmentectomy or lobectomy, or is it pneumonectomy, and how many hours of surgery is it going to be. So definitely we have to give intraoperative instructions and postoperative instructions also. This is really getting into personalized medicine because no two patients will be alike. You also need to look at ABG, you also need to look at the cardiac status, to put everything together. And of course, the CPET is also going to give you an indication, all the other parameters, all the 9 graphs, what he talked about, the anaerobic threshold, the other things. So if you put everything together, then only you can decide on what to do with the patient. So it's like we cannot give a one size fits all statement here. So it is practically individualized, and we should also take steps to see whether it is a emergency or a planned surgery. If at all you can optimize all of this before taking him for surgery, that should be the best option we have. So I have a question to Dr. Johnson Samuel. So you talked about Borg scale. So there are so many dyspnea scales, right? You have a CAT score, you have MMRC score, you have a visual analog score, board index, you have Sherwood-Jones criteria, you have American Association grading. So do you choose your patient? If it is COPD, I will go with MMRC and CAT score, or it is the Borg score which you use generally. So it's so confusing to have so many scores. So why do you rely only on Borg score, or is it that you choose your patients?
We use the Borg score only. And I'll tell you why. Because we have a big chart. I wish I was sitting in the CPET room. I'm not sitting in the CPET room. We have a big chart right in front of the patient. Just before they cycle or they go on the treadmill or the arm crank machine, you have the thing there, and all those 10 things are in big block letters. And we ask them to point, or rather say 1, 2, 3, 4, 5. So where they start there, 1 or something, they say that. When they finish, you don't have to say what you are. You look at that thing and you say 7 or 8. So that's the easiest way of looking at a Borg score. So I would strongly suggest you have something that the patient can see, and also Think about it. The patient has done the exercise, and sometimes they're gasping, they may have chest pain, they may have giddiness. It's useful to say what number. We tell them right at the beginning. These are the things. At the end, you tell me what number it is. As simple as that. I know there are lots of things. NYHA, I mean, you can break your head on it. Have something simple, visual, and the BOG is the easiest.
Thank you. Thank you.
To Dr. Manu Chopra. So, what are the CPET adaptations or markers that are most relevant when evaluating high altitude or diving readiness?
Yeah, ma'am. So as Dr. Johnson said, that these are the individuals who are fit, but they'll come back to us that when I was posted last time to this high altitude area, I could travel so many kilometers, I could go for those stitches, or I could dive so deep. But now I am not able to match my colleagues, or I am not able to do that. So what do I have now? I cannot go to that area and see what he has been doing. So CPET helps me to focus on that what is how much oxygen, reduced oxygen this individual can tolerate, both in a high altitude or in a diving area, and what is how well they can tolerate the increased ventilatory load in all these both areas. So first thing again, as I said earlier, that ventilatory efficiency, that VE by VCO2 helps me out to that. So in these cases, if it is normal, it is good, but at altitudes or during diving where the ventilatory demands are high, if the individual has got a poor ventilatory efficiency, he will have early dyspnea, he will have reduced endurance, and he will not be able to perform the task properly. Second, what I would like to see is oxygen saturation kinetics. So sp2 should also remain in a stable range when when the individual is doing exercise or a workload is being given. So if in these individuals who are healthy, the saturation should remain stable. But if they have an early or a progressive desaturation during exercise, so then this indicates that there is some diffusion limitation in these individuals, or there is a pulmonary vascular abnormality in this patient, or there is some constraint with it. And this will become critically important when these individuals are sent to high altitude areas or when they go for deep sea diving. Third, we have a hypoxic peak VO2. Now, this is the specialized test which we do in some of our centers. Like in Leh, we have got a center, DePass in Delhi, we have in Guwahati. We also have centers in Bangalore. So these individuals are put in these hypoxic chambers and a CPET is carried out in these individuals. So here we see that the peak VO2 with the hypoxia, has it also fallen to the same level as the hypoxia or as the altitude is being given to, the stimulation is being carried out. So if the adaptation is adequate, so the individual is healthy. But if there is a poor ventilatory adaptation, so it shows that the patient will perform poorly at this level. So as we put him into the high altitude areas, there will be a higher chance of altitude intolerance in this patient. Fourthly, then we have a ventilatory reserve. That how much the individual has got a ventilatory reserve, and a healthy individual should have adequate reserve so that he or she should be able to tolerate these strenuous exercises. So what breathing capacity is left unused in these individuals at a peak exercise, and these peak exercises will manifest when we send them to those areas. So if there is a reduced ventilatory reserve, it implies that the individual has got a limiting ventilation, and this limited ventilation is what is causing him to have early dyspnea and is not able to adapt to that environment. Then something known as dynamic hyperinflation, that as the breathing increases, the lungs are not able to exhale out the full air. So we have reduced inspiratory capacity, the tidal and expiratory volume start increasing in these individuals. So you imagine an individual who is in the scuba diver who has been sent down, and with the increased pressure of oxygen of the air which we are giving this individual, he is also not able to breathe out adequately. So he will have more amount of carbon dioxide, he will have this fatigue, he will have this loss of consciousness and may collapse underwater also. Then finally, we have got something known as fine oxygen pulse, which is giving is a surrogate marker of the cardiac condition. So we can, if there is a poor oxygen pulse, as all have told till now, so the individual has got a poor stroke volume, poor cardiac output, though he may have been normal in this condition, but if we put them in strenuous exercises, a normal CPET or a hypoxic CPET, the oxygen pulse is going to have a flattened response. If it has a flattened response, then the individual has a subtle cardiac dysfunction which may manifest as the individual goes up. So I think all these parameters have to be addressed, and in case we truly want to access, as I told, we have got some centers wherein we go for the hypoxic, isobaric and hyperbaric chambers for these individuals and carry out advanced tests. So the individual is actually a malingerer or has a problem which we should be addressing. So these are the complex parameters, I think so, which we have to address in these patients.
I'll add on one more question to you. So, do you repeat the cardiopulmonary exercise testing in these people at regular intervals, or is it a single test that you do on them to see how it is progressing, or are they improving, or they adapting?
So, to be honest, we do not repeat unless we feel that the individual, we are not very sure that whom we have made fit is actually fit, or whom we have made unfit is actually unfit. So we are playing with the lives of individuals whom we are ascertaining that he is going to that area and he will not conk off because of his physiological dependency, or there is some subtle illness which will manifest at these areas. You can't lose a diver when he's gone diving, and or you can't lose an individual soldier to Siachen, not to the bullet of an enemy, but to his own physical intolerance, which he could not do. Second, to be very honest, ma'am, we have got 1.2 million standing Indian Army, and about 80% of that is there in high altitude areas. So it is humanly not possible to do CPET and then repeat a CPET on these individuals. So I will not bluff on that.
Also, we can look into portable CPET, which is also another topic which we are not touching much today. But on the grounds, we are having cardiopulmonary exercise testing, which can be done and results can be got. Now we'll move.
Have that in Leh and 150 GH Leh. We have that. We do that for some individuals at that centers. We have portable CPETs.
Wonderful. Dr. Barney, so I'm going to tweak your question a little bit. So when we are having a patient with multi-system inefficiency, how are you? I'm going to combine one of the questions here, which was looking very, very complex from Vishwesh Shadambikar from Maharashtra. So there are different types of patterns of dyspnea. Now, especially, how are you going to localize the pathology, and how are you going to narrow down the differentials? And also, so I'm taking up anatomy, I'm taking up the when and how of the breathlessness that is happening, because he has asked on a combination of orthopnea, non-cardiac causes, paroxysmal nocturnal dyspnea, orthodeoxia, and diaphragmatic dysfunction. So he has asked multiple questions. So when it is a multi-system pattern, so how do you manage that?
So first of all, I would start from the clinical suspicion. Sometimes you have patients who are known to have one disease, but their symptoms are out of proportion to that disease. So that raises a suspicion of multi-system problem. Or, for example, in some of the examples that Dr. Vishwesh has mentioned, for example, if someone has a known, say, ILD, but they're also orthopneic, but there is no cardiac problem. So it could be a cardiac problem that's not diagnosed by the static test, or it could be something like a diaphragmatic dysfunction. Now, some of these have other measures of assessing. Diaphragmatic dysfunction can be examined by looking at paradoxical breathing. There are other tests to look at diaphragmatic function. So CPET is not something that can diagnose diaphragmatic dysfunction, but CPET is something that will enable us to differentiate additional causes. So that's a starting point. And now when you do the test, I think a couple of points are very important to pick up multi-system involvement. And one of that, I think we have stressed it quite a bit in the last session and today, is that we should have a systematic way of evaluation. Now, if you do not start from the third panel, look at how the slope of the VO2 is, whether there is a additional workload carried by the patient as compared to the where the normal VO2 slope would be, to indicate that obesity may be contributing. And then systematically look at panel 2 and panel 5 to look at the cardiac. Then you look at the left side 147 to look at the ventilatory. Then you look at the right side 6 and 9 to look at the pulmonary vascular. And then after looking at the graphs, you come and check on the numbers to look at all that. It's very easy to miss multi-system involvement. So the first point is analyze CPET systematically. Now, the second thing is when we do report CPET and look at various parameters, we need to understand that certain of the parameters are primarily manifested and certain could be, if I may call it, secondarily manifested. and that wouldn't be very prominent. For example, if you have ventilatory dysfunction as the primary cause, you would run your minute ventilation will run into your MVV, and you will not have a breathing reserve. But there will be an increase in the VE by VCO2 as well. But if the VE by VCO2 is markedly elevated, you know that there is something in addition going up. If the VE by VCO2 is 55 and 60, you know that cannot be explained but just by your primary ventilatory limitation per se. And thirdly, you know that the quantum of limitation, for example, you're dealing with a patient with a mild ILD, FEC is say 70%. But he is out of breathlessness is out of proportion to that, and you do a CPET, and again in early or mild disease, you do not expect your VE by VCO to go up much at all. Probably it may go as much to 35, but it's like 45. Then you know there is an additional component that is there. So that is the second point I would consider. Thirdly, I would conceptually go through what are the combinations that are possible. Some are related combinations, some are unrelated combinations, and some are common unrelated combinations. I would classify it that way. For example, if someone has ILD, a chronic ILD with significant hypoxia could cause pulmonary hypertension just because of the ILD. And then when you do a CPET, you could have breathlessness because of that primary ILD or ILD-induced pulmonary hypertension. Or if you're dealing with a connective tissue disease associated ILD, like systemic sclerosis, we know that systemic sclerosis can cause pulmonary hypertension independent of ILD. So that concept that this situation could cause multiple causes should be there. Or is it like COPD and a cardiac failure? Are there two things going on independently? And some other things like what Dr. Samuel mentioned, like obesity, deconditioning, you know, someone who has got a significant cardiac or a respiratory disease would also be deconditioned. And that also would be, if he's not had adequate rehabilitation, that would also be a contributing factor. So we factor that in as well. And of course, dysfunctional breathing. And then now you look at the parameters. And if I say the primary parameter for cardiac would be oxygen pulse flattening, well, secondarily, you could have occasionally VE by VCO2 going up, but that will only be mild. Similarly, ventilatory, I already mentioned. Similarly, pulmonary vascular, primarily you will have your VE by VCO2 slope going up. And there is not much secondary manifestations on CPET. You will have a VD by VT, which is not falling down, which explains that. But suppose you have breathing reserve that is affected as well, you know there is an additional pathology. So I think systematic approach, looking at what you're suspecting in mind, and if everything is not explained by a pathology, looking for alternate causes would be the approach which will clinch multi-system involvement and help address those in our patients.
Beautifully said. Dr. Johnshon, coming on to misinterpretations. So at what are the common misinterpretations in CPET which can label a patient as anxiety or deconditioning prematurely? So you're on mute.
See, there are lots of answers to this, but I think the first thing you need to make sure that you got right is got the protocol right and the procedure right. If you don't have it right, you can come to any different, three things: protocol, the procedure, and to make sure that the calibrations that you got are right. If these three things are wrong, you can have any number of mislabeling or misrepresentation, as you called it. I mean, if I may say, classic things are there have been patients who have been assessed for fitness for surgery elsewhere who have been deemed not fit for surgery because they have followed a protocol which was not right for the patient. And therefore, we have retested them. Classic example, if you've got a problem with the knees and we ask them to walk, they will give up very early. You don't have an answer, and that and patient gets very anxious and they get more breathless and so on and so forth. So that is something which is very important, the protocol and the calibration. You need to make sure that the readings that you're getting are actual readings. Because if if your machine is not calibrated, then you can get all sorts of answers, and we see this all the time, and you make a wrong interpretations in patients. And the second half of your question was, how are you going to differentiate between a patient who's got anxiety and deconditioning? So the thing about anxiety is anxiety manifests in a lot of ways. And as far as cardiopulmonary exercise test and breathlessness is concerned, you're talking about two big things. One is hyperventilation, and you're talking about dysfunctional breathing, which means it's not to do with the rate, but to do with the patterns of the breathing. So you must remember that if you do the protocol well, which is, I've mentioned this before, and Barney and Ruchi knows this. So you need to have a period of rest and a period of unloaded cycling. Because what you see very, very clearly is as soon as you give even the unloaded cycling, you find that everything goes up, and patients sometimes can panic. And if you don't have that period, and if you go very quickly into a loaded exercise, then you will mislabel every patient as anxiety. You'll mislabel every patient as probably reaching, a submaximal test, for example. So that is pretty important. But the mislabeling usually is you need to be very careful about two conditions. One is hyperventilation and pulmonary vascular disease. Those are the two things you need to be very, very careful about, because both of these things, what are you looking at? BE by BCO2, panel 6. In pulmonary vascular disease, you get it because of VQ mismatch. In these other patients, you get it because you're hyperventilating. Very simply, your BE is very high, your BCO2 is not very much, and you breathe very fast. BE, BCO2 is very high. But then, as Barney said, you need to look at the other graphs, and which is very, very important. In a patient who is hyperventilating or have got laryngeal problems or irregular pattern breathing, they should not reach their threshold very quickly. Okay, so what is a threshold? Threshold has nothing to do with how fast you breathe. Threshold is when you actually switch, and when you find it changes. Okay, so you will find that these patients do not reach their thresholds very quickly in hyperventilators, which means it could be in the normal range. And secondly, thirdly, your actual peak BO2 will be normal in these patients. While you will find that in a patient with pulmonary vascular disease, you have high VQ mismatch, but your peak VO2 may not be normal, it will be low. You may find the VO2 work rate slope is narrowed. So you find other parameters, which is absolutely important. If you do a blood gas in these patients, in patients who are hyperventilating, you'll get the typical respiratory alkalosis, but you will get the very same picture with patients with pulmonary vascular disease as well. But in a deconditioned patient, you may not find that. So you need to look at multiple things, but because it has to be brief and short, the two things you need to be very clear is this patient anxious and hyperventilating, or does this patient actually have a VQ mismatch, such as pulmonary vascular disease?
Wonderful.
There are about 7 or 8 things you can look at, but I've just mentioned the important ones.
Wonderful, sir. And Dr. Ruchi, so how can CPET guide the next step? Whether you're going to reassure the patient, or you're going to put the patient into rehabilitation, or further invasive testing. So,
Thank you, Dr. Supraja. So first of all, CPET is an objective way of measuring the exercise capacity of the patient. And if it has been rightly performed, as we have talked, at the right protocol, the right way, it's in a proper test being performed, then it can be quite a good tool in deciding how to counsel the patient. So if we have a patient with deconditioning, we are able to make a diagnosis of deconditioning based on our CPET testing, then we can advise an exercise regimen accordingly. Right? We can reassure the patient if no significant limitation has been discovered on this testing. Then we can advise, it can be quite reassuring to both the physician as well as the patient in such a scenario. So being an objective test, if well performed, this can be quite a good tool for this, for deciding how to further manage the patient in this scenario. Right? And we have already talked about how we can make a diagnosis of deconditioning or other cardiovascular or ventilatory limitation in various scenarios.
Dr. Thilagavathy ma'am, so can CPET help identify patients who will benefit more from pre-rehabilitation than from delaying surgery?
Very much, yes. So, as I told you, so you can identify patients depending upon the surgery, whether it is emergency or it is planned. It can, if it is not emergency surgery, and if you find there are a lot of parameters, if you subject them to pulmonary rehab and probably repeat a CPET at a later date, maybe the patient will have a easy intraoperative and postoperative period. I think it helps a lot, depends on the surgery and depends on the patient also. So I want to ask Dr. Johnson Samuel. So we usually have this psychogenic female patients, who come and complain of dyspnea, and we run through a lot of tests and then still we don't find anything. So if you have done all your workup and if you have done your CPET correctly, like how you mentioned, and if it says it's all the graphs are normal, are we good to say that this is only psychogenic?
So when you say graphs are normal, you're saying that the patient is not hyperventilating.
Yeah.
Okay. See, I think Ruchi touched on it. One of the best things to tell them is, once you have a test, particularly in patients with breathlessness of unknown etiology or difficult etiology, it's worthwhile sitting down with them and saying, this is the gold standard test. So you have objectively, if you're saying that you've looked at it objectively and you find that the patient is, BO2 is within 80% of what it's predicted, I'm happy with that. If you find the, anaerobic threshold is, well above 60%, which would what I would expect in patients who are otherwise well in themselves. You find that there's no ventilatory or limitation or VQ mismatch, and you find that the patient is not hyperventilating, and finding it is very useful to sit with the patients and tell them, this is the gold standard test. There is nothing we can find as limitation, and there is nothing that we can do to modify your treatment. If I give you an inhaler, it's a waste of time. If I give you any other diuretic, complete waste of time. Perhaps if they have a bit of laryngeal dysfunction, which you can sometimes find in these patients where you have inducible laryngeal obstruction, as we call it, ILO, which is the new term which is used, then they may benefit with voice modulation and voice physiotherapy that can be used. But it is very useful on the one hand for reassurance. Otherwise, and the second side is, if you pick up something even subtle, you can actually help them with that. And one of the things which we haven't talked here is COVID. COVID is a big thing which has happened to across the world, and I don't know how much of long COVID, as we call it, you see in India, but there are lots of patients who are branded as long COVID with lots and lots of symptoms with absolutely no objective findings. Now, it's very interesting because when you have a CPET, we looked at CPETs in COVID, and I think we did a session on that in CMC, looking at what happens in these patients who think they have lots of issues. I've just tested a patient last week who has long COVID, has gone around the countryside looking all over the place, and I've just spoken to the patient, and patient's main problem is breathlessness and chest pain. And chest pain, pain, brain fog, and feeling fatigue are the three big things that these patients have, and breathlessness. So from your side of things, as in from the respiratory side, you can say absolutely clearly, looking at a gold standard test, there does not seem to be significant abnormality. The only caveat to that is, like, as I mentioned, and what Dr. Chopra was saying as well, we do not know how fit they were before. So you could have had a very fit patient who is now in the normal range, which is bad for them. So that is the only caveat, but you can reassure them that you don't have a magic pill to give them to say, take this, you will get better. And some patients do benefit with psychotherapy as well. So the patients who have long COVID, which I've spoken to, we do tell them that sometimes it is difficult because they've gone over, now it's 4 years since COVID or 5 years since COVID. So they've gone over 5 years with all these symptoms. It's not going to go away straight away with you telling them. So they may need some psychological support as well.
Thank you.
moving on to Dr. Chopra, can CPET predict these maladaptations to extreme environments, even before the symptoms occur? So you were telling about the fit and the unfit people who are, being posted. So how do you identify that? What are the maladaptations that you're identifying? Is
Yes,
it only
ma'am.
the standard parameters, or is there anything else?
No, we actually are conducting the research on or studies on these soldiers who are being deployed into high altitude areas. So we have the study running up in J&K as well as in Arunachal, wherein the individuals before they are being posted or the troops when they are being sent to these areas, CPET is being carried out. As I told earlier, also the hypoxic CPET is also being carried out in individuals to assess how fit are they over here, what type level of acclimatization we should advise them, should we change our protocols of acclimatization. So all these things are were also carried out earlier also and still are being carried out. So CPET is actually a very important tool in all these things. It can predict early uh, subtle physiological limitations, maybe cardiac, maybe pulmonary limitations, maybe pulmonary vascular limitations in these individuals who may be fit when they were in their routine environment and doing the exercises. Like as Dr. Johnson and I told, aerobic threshold. So aerobic threshold is very important. If these individuals are able to hit the aerobic threshold too early, so these people are switching from the aerobic to anaerobic respiration or ventilation very fast. So these individuals will not be able to do strenuous exercises or persistent exercises for long. So they may be good enough as a good sprinter. They may do good jobs in a short burst of time, but for a sustained hypoxic environment or a sustained deep diving, these individuals are not good. So CPAT will help me to assess that in these individuals. Second, as we had spoken earlier also, we used to do a ventilatory response. There is a normal ventilatory response. So this individual is not actually hyperventilating. He is symptomatic. He may have a pulmonary problem or a pulmonary cardiovascular problem, and we have to address that. So he is fit as of now, but once you put him to that extreme environment, he is going to fail. We also can have a low O2 pulse, as we discussed earlier, or a heart rate VO2 coupling, where the heart rate with a falling oxygen should also be rising. So if there is some abnormality in that, so these individuals are fit enough in a plain levels or in a normal environment, as we all are sitting as of now, but they are not good enough for strenuous areas. So these symptoms or these abnormalities are already present before they can manifest as dyspnea, fatigue, or syncope. So we are actually assessing them and picking them much before the symptoms can occur. So actually, we are labeling an individual that you have a heart disease, and he says that I run 5 to 7 kilometers per day. How can you say that I have heart disease? So as we all have been discussing, CPET is a gold standard, and if you done CPET properly, then we say that of course my record shows that you have subtle cardiac dysfunction. You need to be followed up. You need to be evaluated. So yes, CPAT can predict adoptions to extreme environments before the symptoms manifest.
The duration we are looking at is few months, right? Or that is what the duration that they're going to be posted?
No, ma'am. Every posting is for 2 years minimum.
Years. Okay, fine. Okay, so you're basically saving them from any catastrophic event. No.
The issue is like, ma'am, so you send them to those areas, you have your protocols over the years which have been followed up, that they are acclimatized to these environments. Now the individual comes down to the base camps or to his home for a small leave. But the individual is so motivated that he wants to go back to that environment as soon as possible. And without realizing that the adaptation has gone back. He may go back to Kerala and now again go back to Siachen. So again, we have to ensure that the individual is fit enough to go back. And now, if after level 1 of the acclimatization, he has dyspnea, he does not have altitude pulmonary edema as of now. It can be just a deconditioning which he had now because of his leave which he had it. So a CPAT is a good investigation for me, that individual, okay, there is no other abnormality except for deconditioning. You have to be slow. You can acclimatize in a slower pace and be fit enough for your posting subsequently. So that is what wherein we put in our CPET.
Just to add to this, because high altitude adaptation is a very, very niche field, and there have been some work from UCL here in the UK who have actually come to Himachal. Mike Rocotte and his team have looked at adaptation of the cardiorespiratory system in high altitudes. So one of the things that two things to state. One, we don't have significant data available and that's the first thing. The second thing is, as you said very clearly, Dr. Chopra, if you are abnormal at baseline levels, then there's no point in even thinking of sending you up there because you're going to be even worse up there. The third thing is a very niche thing which you're doing and looking at patients either in high pressure chambers or looking at low oxygen levels to talk about the heights, and then doing CPET will give you an idea if they are even normal, then they will be able to cope. So that's very important to know. The third point is all humans adapt. So if you may do a CPET on them, as soon as they get into a high altitude area, you're not talking diverse now, you're talking really high altitude. And you may find that they are sort of VO2, let's say for argument's sake, is 35 ml per kg per minute or 25 ml per kg per minute. If you actually do it after 2 months when they're there, you may find that their systems have adapted and you may actually get a VO2 which has gone up by up to 20%. So that is also very important because the human body is very good at adapting, which is why you mentioned very quickly sprinters. The sprinters, your type of muscle fibers are very different from long distance runners. And there are people who can adapt based on your system. So you may not adapt in a month or two, you may not adapt in a day or two, but in a couple of months, your systems can get used to some of these things. Just mentioning, because it's a very important, not very important, very niche area that we are talking about, high altitude and diving particularly.
So in that context, suppose you have a patient, you don't have giving fitness for the flight and things like that. So if you don't have a simulation test ready, can we use CPET to do that also? Do you do that? Fitness for flying.
No, we don't do it. We just give hypoxic challenge. We have the 15% oxygen. So that's much easier. We don't have to get them to exercise, get the test done in half an hour. And we have definite guidelines for, when I say guidelines,
right.
after 15, and then you give them oxygen at that level and then see what happens.
So in a case where you don't have the simulation centers, you only have, like DLCO, PFT and CPET, can you extrapolate or something like that? Can we use it?
I think it's going to be difficult because you're talking about a low partial pressure of oxygen, isn't it?
Yeah.
So you may exercise at the normal levels. That's exactly what Dr. Chopra was saying. What you exercise at normal levels may not be the same as what you're doing up there. So, and you're only checking whom? The patients who are COPD or ILD who are going to fly. You're not checking the normal human being flying, isn't it? So I think it'll be difficult to extrapolate just the CPET on its own. Hypoxic challenge test.
But if the CPET itself is abnormal, can we assume that he may not be, not good to fly?
All COPD patients, it may be abnormal, isn't it?
Yeah.
It can be abnormal. So you're really looking at your hypoxia. What happens at low PO2 partial pressures?
Can I add to this? Yeah, the guidelines mention about this in-flight thing. And they say that if this baseline saturation is more than 95, 96, then usually we can give them a clearance for flight. If I remember it correctly, one of the guidelines, COPD guidelines probably lists it.
94% is what we use here.
Right.
Just to add, not only that, there are several criteria where we don't need the hypoxic challenge test based on walk test saturation. Also, it can be decided. So the recent BTS guidelines on the airway clearance gives those in detail. So only in a subset where we are unsure, borderline, we need to do the hypoxic challenge test.
So, Dr. Barney, can we use CPET to guide longitudinal monitoring when traditional metrics of your cardiac and respiratory tests are all plateauing or they're kind of conflicting with each other over a period of time?
Yeah, that's a good question, but it's often not practiced that way. Often it's used for unexplained breathlessness. There are very few indications where we longitudinally do. But I will look at it in three ways. One is when there are subtle changes. So when you have subtle changes which cannot be picked up by your static test, dynamic test will benefit. For example, you start someone with pulmonary hypertension on pH therapy. and you need to know whether things are getting better and whether you need to add on another drug, or whether some additional therapy is required, or even considering for transplant, or for example, CTEF for a pulmonary endarterectomy. So the VE by VCO2 is a very reliable parameter to look at changes in the pulmonary pressures on exercise. So that's one situation where it can be used. Of late, we have our cardiology colleagues actually referring to us patients with mitral disease, aortic valve disease for CPET. So the reason they're doing is if the CPET is they're doing good on the VO2, they would just continue medical therapy. And they want to look at it over time. And if there is changes, then they're considering to do catheter-guided procedures for those patients, because now they would benefit because they have become more breathless, or they've lost their VO2 because there are subtle changes in the valve. So there is a role for CPET in subtle disease. The second indication is when there are conflicting changes. So first is subtle changes, second is conflicting changes. So you have a patient who has got worsening symptoms. ILD was come with worsening symptoms, but lung functions are normal, or it's not explained by anything that you can find. You think of a vascular cause, you do an echo, but that's also normal, and you know that the sensitivity of echo is only about 65 to 70%. So if you put them on a CPET and they're disproportionate V by VCO2 compared to the breathing reserve or your FEC, you know that there is a evolution of pulmonary hypertension which has happened. So the second thing, when there are conflicting changes. And the third is when you would like to see more robust changes. Now, some of the parameters, for example, walk test, whatever said and done, is a submaximal test. For example, in the current rheumatology guidelines, walk test is out of the box in CTD ILD, because, for example, if patients have knee problems, you cannot reliably do. But CPET can be done, the arm cramp can be done if their arms are okay. So there is a robust testing where other testing are not very suitable. So we could use it for longitudinal follow-up.
Okay. Now we will start taking questions from the audience, because we are having another 15 more minutes. I'll quickly run through those questions which have been covered already. I will just give the credit to the persons who have asked. The first question which I asked Dr. Johnshon was from Mehak, Maharashtra. What is the most important question? Second was Vishwesh, which Dr. Barney has already answered. Third is Atif Patel from Maharashtra, whose question is, what questions help identify occult heart failure with preserved ejection fraction? I'm not sure what questions will answer that. Dr. Barney?
I think what they're trying to ask is, the heart failure is not seen by conventional test like echocardiogram, and so it is occult, and you do a CPET and it shows oxygen pulse that's flattening. There's an early anaerobic threshold, and now you go back to the cardiologist, repeat an echo, or do more invasive tests to diagnose or treat.
Okay, but I believe the presentation itself will guide us, and then the echo should also tell us, and with other markers, biomarkers which are available as your NT-proBNP and other markers, I think those will start off first, and then looking into CPET. Thank you, sir. And next question is from Tina Anand, Maharashtra. What are the dyspnea scales most useful? As sir has said, one scale, box scale. I think we'll stick on to that. Pooja Thakur Daman, on what red flags in history demand urgent action, even if the tests are normal? I'll give that question to Dr. Johnshon.
I think that's an interesting question. But brings you back to the paradigm which I put across. What are you trying to answer? I think as a physician, that's the first question you need to ask. So if you ask simply what are the red flags, the only patients we test are the patients who are, their symptoms are out of proportion to their baseline test. And one of the things I was going to show you was a test in a patient who is breathless, but is able to cycle about 10 to 20 miles. So that is got to do significantly with malingering. Okay, so you need to get a story, as in the history, ask them primarily we're talking breathlessness today. We're not talking chest pain. We're not talking prognostic indicators or those sort of things. We're talking breathlessness. The patient is breathless. It may be worthwhile, even in the history, to be able to say, is this fitting into a pattern? Because we all have clinical syndromes. You need to look to see where it is. But the one thing, if you say a red flag, and the dangerous thing that you may pick up in breathlessness patients is occult pulmonary vascular disease. I'll just give you an example. I had a patient who was referred from another trust simply because this patient is very fit, going on a backpacking holiday across Australia. I don't know if Barney was here. No, he wasn't. I think backpacking holiday. And the patient is breathless, and the referring consultant knows this patient, and this patient has there's no anxiety, there's no problem there, and the referring consultant has got this suspicion, so they've sent it across, and we did this patient's CPET, and it's got chronic, it's got very classical VQ mismatch. And we know very, very clearly it is not a cardiac. We are able to pinpoint that the VQ mismatch was out of proportion to any of the other parameters. And we said very clearly, in a young woman, you're looking at pulmonary vascular disease. And lo and behold, you don't do a CTPA initially in a patient who is otherwise well. Did a CTPA, there was something which was very non-specific. So I actually went on to do in Papworth and Cambridge. We referred them there because there was a very classic change on CPET which couldn't ignore, and there was a web in the pulmonary artery and causing pulmonary hypertension in one area, which they were able to treat very easily. So if you say red flag in the sense that something you should not ignore is if you've taken a good history, got the baseline test, and the patient is not malingering, or there seems to be a genuine case, that I think should be the most important red flag. And in my experience, the number of patients that you pick up with pulmonary vascular disease occult, or they may have had a thrombus which they may not have ever known about in the past, and they've come with chronic thromboembolic disease. So that is the ultimate red flag. But must take a history, must look at the primary investigations that they have, and then you need to take it from there.
So in this, as the case you said, so where do you place the lung perfusion scan in between your DLCO, PFT, and your CPET?
The short answer is we don't do much lung perfusion scans anymore. I don't know about in India, because the reason we don't do it here is because, as you know, there are a lot of false positives and false negatives in a perfusion scan. That's one. And the second thing is it has to do with the person who's interpreting as well. And we have lots and lots of radiologists who haven't interpreted lung function perfusion scans.
So in this patient, how did you find out that web? Because CTPA was normal, right?
No, there was the CTPA was not normal. It didn't show a clot, but there seemed to be a query thickening of the artery, of the pulmonary artery, but you couldn't see the web.
So you can have a pulmonary microangiopathy, right? The clots can be distal.
Yeah, no, but this patient actually had a web. They actually have done an angiogram in her and did find a web. Yeah.
So they did an invasive pulmonary angiogram. So that's a question probably I'm asking.
Yeah, sure. That's right. Invasive pulmonary angiogram.
Yeah. Thank you, sir. And Pooja, there goes the answer. Next question, I'll post it to Dr. Ruchi Dua from Puneet Bajaj, Mumbai. How do you differentiate dyspnea from fatigue or exercise intolerance? In a CPET, I presume that.
Yeah. So you mean to say deconditioning or?
When we say patient is exercise intolerance, I think this is a common terminology which we are using in our practice. Patient is exercise intolerance, they're not able to do or like that. From fatigue, muscle fatigue or long COVID from that.
So what I do understand is that just like we talked about it, if the patient has reason for any ventilatory limitation for that, and so like breathing reserve can be a very important indicator for knowing about the ventilatory limitation. Fatigue is a very general kind of a symptom actually. Are we talking in context of a long COVID syndrome for that matter? Or there it can
have to give it as a generalized
abnormalities even in long COVID for that matter, right? I think the sir would like to add something to this question because
Yeah, I was going to say the fatigue. You see, fatigue is again a perception. You don't have a scale to measure fatigue. The one thing that you can say is this test submaximal or not? If the patient has got fatigue and it's a submaximal test, then you need to look at why it is a submaximal test. Is it to do with any functional change, or is it to do with deconditioning? Those are the two things you need to differentiate. Is it the patient who is not doing the test? Because if you take a static test, for example, your spirometry, is so variable, it is so dependent on the patient. You can do a foo or you can do a proper blow. And it depend if the other person doesn't know what they're looking at, then they can interpret it as a severe lung disease, or you can say the patient has not done a blow. The best thing about the CPET is you cannot cheat the system. You can look there to see if the patient's systems have got enough heart rate reserve, you got enough breathing reserve, you haven't even gone anywhere near a anaerobic threshold, and you're saying a fatigue. It's usually it's in patients who have got known function non-physiological things. That would be the first thing to say. In some patients, you can have after a major illnesses of any kind. You can have prolonged ITU stay, you can have significant fatigue, and I think Dr. Thilagavathy did mention about patients who have pre-operative chemotherapy. They can have a CPET. For a short period, we were doing CPETs in patients who are going for esophageal cancer surgery. So they get pre-op chemotherapy, and then post chemotherapy, you find that their symptoms have that their CPET parameters are significantly decreased, and that is significantly due to two things: deconditioning because of the disease itself, and two, chemotherapy itself causes decrease in muscle mass. So, you need to see submaximal test. Is it deconditioning in patients, or is it totally functional because it's causing submaximal? I'm not sure if it's answered the question, but I can't think of anything else to say from that way the question was framed.
Yes. I'll put the next question to Dr. Thilagavathy, ma'am. From Shiyaj Thakur, Rajasthan. What are the minimum initial tests that must be normal before we label it as unexplained?
We just discussed. So this is the most trickiest problem. Anybody comes to you with this unexplained dyspnea, even after running through all the tests, you are stuck somewhere, and the patient that's practically what we were discussing with Dr. Johnshon, I think, right? So even everything is normal, and still, as I rightly told you just now, we were discussing, even the CTPA can be normal, and still the patient will say they are breathless. I have, post-COVID, especially microangiopathies, which are very, very difficult to pick up, and then to label them as, you don't say that you are only malingering, your psychological. It's the most difficult answer, or the difficult question to answer. But we should be systematic in our approach. We should not miss anything. You cannot you cannot get away without a cardiac evaluation. You cannot get away without an ABG. You can have now SGLT2 receptor, antagonist diabetic patients. They can have non-acidosis. They present with acidosis where they have only dyspnea as their complaint. I've seen so many patients like that. You do all the lung function, everything will be normal. You run through the CT scan, you run through CTPA, everything will be normal. Just because of that drug-induced acidosis, this patient will have breathlessness. So it's quite a difficult scenario to answer this. I think we should be systematic in your approach and not miss anything. That's the most important point here. Anybody wants to add anything? Yes.
I think literally we have to, system-wise, we have to do all the tests and then look into it. Next question, I will, what are the differences between CPET and routine exercise test from Meena Chawla from UPA? I'll post it to Dr. Barney.
Sorry, what's the question? Routine tests and
what is the difference between a CPET and a TMT? Routine TMT.
Okay. So TMT is looking at only the cardiac component, whereas CPET is looking at all components, including cardiac. In fact, it has a TMT inbuilt in it, and it's looking at many other things as well.
Yeah. I think we'll be brief with all the answers unless it is requiring extreme, in-depth explanation. There's one question from Atif Patel because I want to give credit to whoever has asked. What are the different types of exercise protocols? I think you should look into the first part of this webinar to understand that. And Pratik Seth from Madras, what time frame should qualify as unexplained after initial workup? I think at the end of your initial workup, if the patient is you're not identifying and the patient is breathless, I think that is enough. You don't have to wait for a longer period of time. Seema Singh from Punjab, how do you grade dyspnea severity in a consistent way? I think there are several scores and you stick to a single score and find it out. Payal Patel from Rajkot, how reliable is patient reported breathlessness compared to objective measures? Shall we discuss on this?
What is the question?
How reliable is patient reported breathlessness compared to objective measures? Because we're talking on unexplained dyspnea.
Breathlessness is always patient reported.
Yeah.
What we are finding is what we are finding. I think the two are independent of each other.
Yes. Manan Mathur from Punjab, what are the common pitfalls that make dyspnea seem unexplained? I think we have looked into the pitfalls in different aspects. Sheena Laha Bengal from, how do you ask about anginal equivalence in dyspnea patients? Do you ask about angina equivalence?
I think this is a multidisciplinary approach. You need to involve a cardiologist in this stage and go through the biomarkers and everything. It is not like with one test we can give away saying you have angina or not.
Okay. So also the ECG changes. Dr. Johnson, would you like to add on anything?
No, I was just going to say that quite a lot of the time, the patients who come to evaluate unexplained breathlessness have seen a cardiology, have had the test, have had their resting tests, and some even exercise tests. But one of the things I think Barney touched upon is multiple systems being involved. You must never forget that you can have a little bit of diastolic dysfunctioning, you can have a little bit of ventilatory limitation, you can have had mild COPD. So just looking at COPD in itself is not enough. But when you add everything together, you will find very interestingly, graph 3 or plot 3, you will find that the peak VO2 is lower. You might find VO2 work rate is less. You cannot explain it to just one. So you can say it's a multiple pronged approach that you would get.
Thank you, sir. So next is Jay Kishan from Punjab. How to overcome limitations of CPET with multiple questions, multiple scenarios he has given. I think as sir said, the protocol, the way you're doing your assessment and questioning, history taking, I think we have discussed in detail, and going by a stepwise approach will help you differentiate all the different scenarios. Shobha Shah from Mumbai, indications of CPET. I think we have discussed that. And Vibha Chawla, Maharashtra, on role of CPET and pulmonary hypertension. This was discussed in the last webinar, and to a certain extent in the current thing, how it is interpreting and what are the graphs that you're going to look into. We have discussed that.
Just to add that the CPET parameter of V by VCO2 is in the traffic light risk stratification of pulmonary hypertension to decide on therapy.
So, yes. And then on Chintan Mehta, on CPET and preoperative evaluation, we have discussed that in detail. Palaksha, CPET in obesity and deconditioning, and that was one of the major questions that was actually posted to Dr. Johnson, and he has explained beautifully in terms of obesity, in terms of deconditioning, and how you have to differentiate it from a pulmonary vascular cause. He had said that beautifully. Ishita Bajaj on absolute contraindications to CPET. I think you have to visit the first webinar where Dr. Saurabh had beautifully explained that. And Subhashini in Tamil Nadu, Vellore, do you have different CPET protocol for exercise-induced breathing? I will give that to Dr. Ruchi Dua.
For what? Yeah, sorry.
Do you have different CPET protocols? So you have the RAM protocol, the continuous protocols.
Yes,
Bruise
yes,
and,
we do have. Yeah.
For exercise-induced bronchospasm.
Incremental, and there's certain important thing that the target heart rate and the ventilatory rate has to be achieved to say that the test has been rightly performed. Right?
Okay.
Yep.
Fine. The next question, I think the questions from Vishwesh are quite big. Pre-test preparation regarding food and medications which should be held. I think all these have been covered in the first part. Criteria to define a maximal effort, causes, why do you use an aerobic threshold to distinguish deconditioning. I think this has been discussed at different parts in the part 1 and part 2. Subhashini, how do you differentiate between oscillatory pattern in cardiac limitation and dysfunctional breathing? Dr. Johnson, please. I know we are exceeding time, but we wouldn't want to miss out your answers as well.
That's a good question, because you find oscillatory patterns in both cardiac failure and in patients with dysfunctional breathing. The one thing that you could use to differentiate is in cardiac failure, once the oscillatory pattern starts, it continues. Because once you reach the stage where you have that up and down change, when your stroke volume is not keeping up, it will be a continuous process till you finish the test. But the classic thing you will find in patients with dysfunctional breathing, it's completely episodic. You can tell them, one of my cases, which I didn't show you again, was a patient who has, do you know if you hyperventilate, you can get T wave changes on an ECG?
Yes.
So that is very, very interesting, because you can tell them, stop your fast breathing, breathe slowly, show them how they do it, and you'll find that the ECG markers change. You'll find the oscillatory patterns change, but you'll find that the VO2 is climbing very normally, because what they're doing is dysfunctional. While the oscillatory patterns is a continuous thing, and you'll find that quite often when you hit that, your VO2 is not going to go up as well. You'll find your oxygen pulse already started flattening, because your heart rate is then going to take. And so multiple things you can use, but one is almost continuous from the time it takes off. The other one is sporadic, and you can actually get them to stop.
Wonderful. Next question is from Sharwari, Maharashtra. What are the main clinical indications? We have discussed that. How do you differentiate TMT or stress ECG from CPET? We have discussed that. I'll post this question to Dr. Manu Chopra from Dawal Patel, MP. Normal VO2 values in adults, and how do they vary with age and sex? But I would like to slightly tweak it as well into what are your VO2 values in your super individuals?
The normal VO2 values in super individuals, we do not take like that. The normal VO2 values we have to predict for our individuals. So as Dr. Johnson also saying that for about normal individual, about 50 to 60, 45 to 50, 65 is the normal which we are taking. And in case of no, super individual, it won't go to 80. So what we take is 25 to 45, below 25 we have normal. So we also take like that also. It is an individual as it is. So 25
So
to
you're
45.
generally looking at around 45, which is a very good.
Yeah, so we don't go 55, 60, 80. We don't go for that.
Okay. Because on a general note, when we are doing it for people who are here without any cardiopulmonary, we are looking at around 25 to 30, even in well-trained individuals. And patients, of course, we hope that they don't go below 20. So that is how it is. And yes. And what is VO2 max and what does it physiologically represent from Bhavesh Parmar? I think we have discussed that. What is anaerobic threshold? How is it identified? Manan Mehta. I think all of you should visit the first webinar series to understand all these. Girish Anand, what is the clinical significance of a reduced anaerobic threshold? I think this is one question I think quickly if Dr. Johnson can answer, because it's not always abnormal. So if you can put a perspective to it.
Sorry, the question is?
Clinical significance of reduced anaerobic threshold.
Oh, it just tells you there is disease. Simple. If anaerobic threshold should be more than 50% of your peak VO2. If you're finding that the anaerobic threshold is very early, or the percentage is less than 40%, then anaerobic threshold percentage means anaerobic threshold compared to your peak VO2 less than 40%. It just tells you that it's disease. It just tells you. It doesn't tell you what disease it is. It could be cardiac, it could be respiratory, ventilatory, it could be VQ mismatch, it could be muscle problem. We haven't even looked at muscle problems, because there are a lot of mitochondrial myopathies and other things which can cause very different changes that you will see in these patients. But what is the level? Less than 40%? Definitely. And very simply, early early 80 is bad.
The next question is from Chaya Davda from Mumbai. What is the RER ratio and what is the value which indicates maximal effort? We keep it at a ballpark mark of 1.15 and above is normal. And Payal Sinha from Mumbai. How do you differentiate cardiac limitation from pulmonary? We have discussed that. Tina Anand, what CPET findings suggest deconditioning as primary cause? I think we have touched upon that. Shavari, what is the significance of oxygen pulse? And what does a low value indicate? I think we have covered. Nita Tanna from Mumbai, what is ventilatory efficiency assessed using VV CO2 slope? How is it assessed using VCO2. We have discussed that. And in fact, last time, the number of questions on V by VCO2 was so much. Again, all these people, Jagdish Patel, should visit that. What are the abnormal values and clinical importance? Sheetal Sharma on what are the CPET patterns which are seen in heart failure with reduced ejection fraction. I think that is graph 2, 3, and 5, which you will look into, and the O2 pulse, initial part of this discussion, which you should look into. Deepthi Rathod, what CPET findings are suggestive of pulmonary arterial hypertension? Again, recently discussed. Dilip Thakur, how does CPET help in evaluating unexplained dyspnea? It is the whole presentation that has happened today in the last 2 hours. And Seema from Maharashtra, what are the CPET features seen in interstitial lung disease? So the 7 graph, which you didn't talk about, would you like to talk about that in 1 or 2 lines for ILD?
You're talking to me?
Yeah.
Okay. So
because there was one slide which you left out at that time because of want of time.
yes, I mean, first thing to say is there's no specific feature for ILD. Because you're not saying there's a COPD or ILD or pulmonary, you're just saying there's a defect. What you will probably find is the dead space in these patients are significantly increased in graph 9 compared to your, and it'll rise in proportion to your VE in graph 9.
Also, to the person who has asked a question, usually
Sorry, graph 7
identify ILD in a CPET. So,
sorry, it's not graph 9, it's graph 7.
7 is what, yeah, we were talking.
So the basic thing is CPET will tell you why your patient stopped exercising. It cannot label any disease.
Exactly.
So you need to understand, and sir rightly said it can be 1 + 1, this plus that, it can be many.
Yes. The last 4 questions. Payal Kotari from Nagpur, what are the parameters which are useful for preoperative risk? We have looked into it. And Chandana Vora from Gujarat, what are the contraindications? Go to part 1. Once Mavani Pune, how does CPET help in differentiating obesity-related dyspnea from cardiopulmonary? Again, the initial part of Dr. Johnson's talk. And final question from Shavari Maharashtra, what is the prognostic role of CPET in chronic heart failure and pulmonary hypertension? I think, sir, can any one of us discuss on the stratification risks and the 5-year mortality? Quickly on this, please.
The short answer is it has got a very significant role. And what we do here is, Barney mentioned a bit about thromboembolic pulmonary disease and when you start therapy and to see the effectiveness of therapy. The other big thing we do here in our center is to evaluate, at least in the British Heart Association, when do you put a patient for cardiac transplant? So those patients, we serially do CPETs on these patients, and when you have a peak VO2 which is dropping less than 10, you really from 12 to 10 you're starting to put them onto the system, but less than 10 they are absolute candidates for cardiac transplantation.
So
and there's adult congenital heart disease as well. That's a big topic on itself. We won't go there. So it's got very important things of when to intervene, do other things, and treat pulmonary hypertension aspect in adult congenital heart disease.
So we have gone a little bit past time. So to summarize, what we have discussed today is what are the, in an unexplained dyspnea, how do you interpret the CPET and how do you arrive in a very, very systematic way? And sir, to your information, we all use the traditional Wasserman. So we are comfortable with the numbers that you have said as to 235 for cardiac and 147 for respiratory and 469 for vascular. So on that we discussed, and then we started discussing with Dr. Ruchi Dua on the other aspects of exercise-induced bronchospasm and other aspects of unexplained dyspnea. Dr. Manu Chopra was good enough to discuss on the other extremes of extremely good health and how the different CPET patterns are going to help his decision making. And Dr. Thilagavathy ma'am had put perspective as to in a preoperative setup, how do you use a CPET and how do you criteria-wise differentiate, and when do you rehabilitate or prehabilitate all these patients? So in a mixture, because CPET is a difficult topic, but why did we choose this topic is because there are not so many centers, but yes, definitely multiple centers have started coming up with CPET. The utilization and the usage has been recognized, and people are interested in understanding the physiology and tailoring, as rightly put, personalized therapy is coming up in a big way, and they want to identify what exactly is the cause, go to the problem, and then address it. And even if it was normal, tell them that reassure them that this is absolutely normal. So a wonderful job done by excellent speaker, Dr. Johnshon from UK, who has taken time to spend his 2 hours with us during his work hours, and the rest of the panel from east, west, north, and south. As I love to say it, Dr. Ruchi from Rishikesh, Dr. Barney from CMC, Dr. Thilagavathy from Chennai, and Dr. Chopra from Pune. So thank you so much. And again, I have my heartfelt thanks to ICS for giving us this wonderful opportunity to discuss, and hope we will be having workshops shortly, like the other workshops that we are having. We will plan that and we'll get back to you, because this is just an eye-opener, an introduction into cardiopulmonary exercise testing. Maybe we should have 1 or 2 day workshops to understand the concepts and hands-on for you all to know what it is. And it is an upcoming topic, and there are many centers which are coming up with that. So I thank Dr. Rakesh Chawla, Dr. Amita Nene for this opportunity, Sipla Vipul for giving us this academic support, and Sheila for their support. Thank you so much. And
Thank
thank
you.
you to the audience
Thank you.
To
because
ICS
you
for
have
this
posted so many
opportunity. And
questions.
yeah, thank you. Yeah.